The following podcast is part of a certified educational activity titled Alzheimer's Disease Case Conference, Acquiring New Skills and Visualizing Emerging Strategies for the Era of Amyloid-Targeting Therapies. Access the entire activity and complete the post-test at peerview.com/CAF860. Downloadable slides and practice aids are also available.
Hello, welcome everybody, and thanks for joining our symposium here, which is called Alzheimer's Disease Case Conference, Acquiring New Skills and Visualizing Emerging Strategies for the Era of Amyloid-Targeting Therapies. So we are happy to present a panel today of distinguished speakers and panelists, starting with Professor Silvia Morbelli, full professor of nuclear medicine at the University of Turin. And then Professor Satoshi Minoshima, the Anne Osborne chairman and professor of the Department of Radiology at the University of Utah. And I myself am based at the University of Cologne in Germany. So the goals for today is augment the knowledge on imaging, provide guidance on the benefits, improve your abilities to utilize communication strategies, and equip you with strategies for integrating the current and emerging PET tracers into clinical workflows to facilitate diagnosis and also for the workup for amyloid targeting therapies. All right, and then we'll go right into the topics, and I will start with a presentation on the theoretical frameworks and the clinical tools for AD diagnosis. To start with the neuropathology of Alzheimer's disease. So for many years now, it has been divided in three categories, which is A, T, and N. A standing for amyloid pathology, the extracellular aggregation of amyloid. T for tau pathology, the intraneuronal aggregation of tau. And N for neuronal injury, the resulting dysfunction of synapses of neurons, and finally their loss. So on top of these concepts, new causal therapies have been developed based on antibodies binding to amyloid and removing it from the brain. And you certainly have heard about these drugs that also gained approval. That started with the aducanumab that gained FDA approval in 2021. The lecanemab, which gained FDA approval in 2023, is currently in EMA revision in Europe, and the donanemab, which also gained FDA approval in July of this year and filed for EMA approval as well. So why do we need biomarkers for these new therapies? Basically, there are three limitations. One is it's not easily possible by clinical assessment to verify the disease pathology, because it is not 100% reliable what we see from the outside with regard to symptoms. The early detection of pathology is nearly impossible because there's a long delay between onset of pathology and onset of symptoms. And also therapy monitoring is difficult because removing this causal pathology is not one-to-one translated into a change in symptomatic appearance. So biomarkers are required. And we basically have three ways available today. This is imaging biomarkers that we will talk about here today, the CSF biomarkers, and recently also the blood biomarkers entering the field. So with regard to imaging, we are in nuclear medicine in a very comfortable situation because we have tracers for all three categories available. We can do amyloid PET for the A category, we can do tau PET for the T category, and we can do FDG PET for the N category. But also there are, as I mentioned, plasma and CSF biomarkers that also can basically assess these three categories. The amyloid in the CSF will be reduced in patients with Alzheimer's disease, probably due to the fact that the amyloid is stuck in the brain and does not show up in the CSF. So you can measure it in the CSF. But also tau pathology fragments are to be detected in the CSF. And also sort of an N category, the neurofilament light chains can be assessed here. So the most recent development is plasma biomarkers. Here the development is even more problematic because these changes need to be translated into the plasma. So they need to transfer or cross the blood-brain barrier. So you need very, very sensitive tools to depict these changes, which basically go into the same direction as in the CSF. But what about the use of these tools for therapy, selection, and monitoring? It is obvious that amyloid PET really played a pivotal role for the approval and success of these therapies. And that is with regard to patient inclusion, because patients could be selected that actually have the target in their brain reliably. And also it was possible to demonstrate that the amyloid is really removed from the brain. And that was the case in the first trial for aducanumab, and recently also for the lecanemab, which you can see on the right side of the slide. On top, you see in orange the placebo. The PET level is the same. In the blue curve shows the response to the drug, and you can see that the amyloid levels are clearly decreasing. But not only this, on the bottom of the right side, you see the clinical course, and as obvious with the lecanemab, the clinical course has a delay as compared to the placebo. So patients do not get better under this drug, but they get worse less quickly. So the process is delayed, in that case very significantly, so it's quite obvious there's an effect. For the third drug, the donanemab, amyloid or PET imaging played an even more important role, because it has been used here for inclusion of patients first. Then tau PET has also been used for inclusion of patients, and patients with very low tau burden have been excluded because it was expected they wouldn't show a change in that time the study is performed. And then the third, amyloid PET, was also again used for monitoring therapy effects, but also for switching therapies. So in patients that had decreased with the amyloid levels to basically amyloid-free in their brain, they were switched to placebo afterwards, which is a new kind of approach, employing again PET as the core method for applying this therapy. And I showed the clinical response associated with this before. So I want to quickly touch now the new biomarker categories, because so far we had this ATN classification, which was relatively clear. Now it moved towards a new category, which has been published by the Alzheimer's Association. The reason for this new category was based on a number of facts. One is that there was the discussion, should diagnosis of Alzheimer's disease require all three biomarkers, A, T, and N, or are two or only one reliable enough? Second, there's a need for staging and not a binary detection, which is fair to say. We don't want to just see A plus, A minus, but maybe levels of pathology in the brain. Furthermore, it was becoming obvious that the so-called A, T, and N markers in themselves were not equivalent. So imaging A is not the same as CSF A. And finally, also some of the fluid biomarkers are not pathology specific. So one of the most successful ones, the p-tau 217, and you see this on the right side of the slide, is not only correlating with tau, it is also correlating with plaques in the brain, and the best correlation was found in basically an interaction of plaques of tangles. So it is a tool that captures Alzheimer's disease pathology, but not specifically only A or only T, so it doesn't fit into this ATN classification. So what were the consequences in these new categories? There is a stronger focus now on disease stage than on etiologic specificity. And they benchmarked the biomarkers towards the so-called ADNPC, the Alzheimer's disease neuropathological changes, which basically is a sum of pathologies in the brain, not a single etiologic pathology. Also, they introduced instead of the ATN, so-called core biomarkers, core 1, bundling biomarkers of early diagnosis, and core 2 bundling biomarkers of later stages. Finally, they split the T markers into T1 and T2, reflecting, as what I mentioned to you, that there are early biomarkers, tau biomarkers supposedly, that even correlate with amyloid in the brain, which would be capturing early pathology, and the T2, the later ones, which can be captured with PET. So to summarize, which biomarkers are we talking here about? And on top you see the core 1 biomarkers for plasma, CSF, and imaging. So we can see here that the A-beta 42 to 40 level in the CSF would be considered an A marker reliable for a core 1 diagnosis. Also the amyloid PET. For the T1, which is also part of the core 1, it would be the p-tau 217 and other similar fluid biomarkers. And there are also combinations, such as the ratio of CSF p-tau towards A-beta 42, which is also, again, a mix of amyloid and tau signal that is here used for a classification. So I put here in green which of these markers are approved. And this is amyloid PET and the two combination biomarkers. That would be defining a core 1. Core 2 would be defined by tau PET, as we can see, also as an approved tool. And other CSF and blood biomarkers are discussed here, but not well established yet for this core 2 assessment. So after that, in that new classification, there are N biomarkers added for non-specific processes here, which would be FDG PET, MRI, and the NFL markers, and inflammation markers such as the GFAP that can be assessed also. And then they would also list here biomarkers of non-AD co-pathology such as vascular, which could be measured with structural imaging, and synuclein as accessible by the new synuclein seeding assays. So what would core 1 tell us? Or help us? It would be helpful for early detection of Alzheimer's disease in people without symptoms. And this is very important according to this new classification. Any person having any core 1 positive biomarker would be considered to suffer from Alzheimer's disease. So with only an amyloid marker being positive, you'd be considered to be suffering from Alzheimer's disease. And also it would be helpful, according to these guidelines, for confirmation of Alzheimer's disease pathology and symptomatic symptoms. The core 2 diagnostic use would be adding increased confidence that Alzheimer's disease is the reason for the symptoms, and it would be helpful for staging the disease. Here, particularly, the tau PET is discussed as a biomarker, so imaging has a prominent role also in this new criteria because they suggest you could stage the disease better with the core 2 biomarkers, so with the tau PET basically, as compared to the core 1. And it would also inform on the risk of progression. So how would we stage with these markers? As I mentioned, this also the reason was to improve staging. They here divided between biological staging, which basically would be initial stages having amyloid positivity in the amyloid PET or any other of the core 1 biomarkers. And then the subsequent stages, such as early stage, intermediate stage, and advanced stage, would be measured here with the tau PET. So mesial temporal tau would be an early stage biomarker, moderate tau would be intermediate, and in neocortical, higher neocortical regions, it would be an advanced stage. So a combination of both would be used for biological staging. There would also be clinical staging, starting with 0, asymptomatic biomarker negative, 1 asymptomatic biomarker positive, and then 2 to 6 different stages of severity. And this is, again, important to have a look at because the third line is integrated staging, which combines the biological and the clinical staging. However, if you have a close look at the clinical staging, this already is combining because at the stage 1, here called clinical, you would need a biomarker positivity and asymptomatic stage. So it's not purely clinical. Already the clinical staging has biomarker integrated, which is making it a little bit confusing maybe. So these new criteria are certainly aiming towards important questions and also providing guidelines for application of the biomarkers. But also there are some controversies and questions with regard to our imaging tools that we need to be aware of, in my opinion. Core 1 is, I think, an important information, should be sufficient for diagnosis of Alzheimer's disease as a disease. So as soon as one core biomarker is positive, you would be suffering from a disease. And it's probably debatable. Let's say in Europe, we would have then more than 30 million patients immediately because subjects being in stage 1 having no symptoms, but some amyloid positivity. Of course, an important discussion. Core 1 biomarkers represent ADNPC. So they represent, as they stated, Alzheimer, A-beta pathology and tau pathology in a general form, which is, to my opinion, not true because we have PET biomarkers such as amyloid PET who do only selectively represent amyloid PET. They had to be tested in that way. And there have been other tracers, you may remember, that were not specific. They were binding to amyloid and tau at the same time, and they never made it. They were not successful because they were not specific. We have this situation now for some of the fluid biomarkers. They also claim that core-1 biomarkers are interchangeable, and I do not quite agree. I do not believe that the aggregated amyloid beta that we measure with amyloid PET is the same as what we see in the CSF or in the plasma. They may reflect the same pathology, but not the same stages. And there again, I wonder why amyloid PET is not considered also as a tool for staging in core-1. We have the centiloid scale that is not mentioned, and they divide the T markers in T1 and T2, but they do not for the A1 and the A2. This is also maybe something that needs to be considered also for the future. Then what about core-2? They mention here there's a combination needed with a core-1 biomarker, meaning amyloid positivity, and then you can stage with the tau PET. But, and this is obviously a question, if you already have a positive amyloid marker, you can also stage with, for example, FDG PET. Where's the difference then? This is not a non-specific biomarker. And the fluid biomarkers in core-2, I think, are not sufficiently approved yet. Then non-specific and non-AD biomarkers. They call FDG a non-specific biomarker, but many of us will know there have been several autopsy studies, and Dr. Minoshima may also be talking about this, that have proven an autopsy-based value of FDG PET towards the so-called AD-NPC pathology. And also FDG PET has a value of the patterns, not only of a category plus or minus. And I think this is also a little bit disregarded in this biomarker classification, that there's more information in an image as just a plus or minus or a level. And also I find it interesting that no biomarkers of dopaminergic degeneration are mentioned, because they do mention the CSF assay of synuclein aggregates, but do not mention markers of dopaminergic degeneration, which are well established for getting this diagnosis. Some more general question is, I can see or understand the value in staging. That was, let's say, a need as compared to the classic ATN classification. But it is a bit interesting how it's now moving from etiology specificity of the biomarkers to rather stage-specific biomarkers. And I think if we have very specific therapies, we should also focus on how specific are the biomarkers. That is a little bit lost here. A really major discussion point, I think, is that co-pathology is not discussed. So if a patient, let's say, has dementia with Lewy bodies, many of those will be amyloid positive, about half of them. So according to this new criteria, they would all be called Alzheimer's disease, which I think is not fair. So there needs to be some added information to come to this diagnosis. So just to visualize on what is now core-1, many of you may know this graph that ordered the appearance of the biomarkers in the past. And we see here CSF and plasma A-beta 42 would be the first to appear, followed by amyloid PET, followed by p-tau in CSF and plasma, followed by tau PET, the yellow curve, and then MRI and symptoms. So according to the new criteria, all this that I circled here would be now core-1. So it is also in a way undifferentiated to stages in the early phase. And the tau PET here would then be the core-2. I see a little bit of a danger here, because we know from publications also that there are patients who are CSF positive or fluid biomarker positive already, but not yet PET positive. And they have a very good prognosis, so they may be stable a long time, which is the yellow curve here on the right side. Whereas the CSF positive plus PET positives will have a steeper decline. So obviously there's a difference between the two biomarkers, and I find it difficult to put them into one box and just say they are core-1. Does not necessarily make sense from my perspective. With regard now aspect to the imaging applications, not to this guideline in general, that needs to be said. So with this, I would like to hand over to Professor Minoshima, who will teach us about the value of FDG PET again in improving differential diagnosis.
Thank you so much for inviting me to this session. I'm asked to talk about FDG PET for differential diagnosis of dementia. And probably all of us in this audience knows what FDG is. And this tracer was actually developed for brain imaging almost half century ago. And the brain is a very interesting organ. There is no energy storage. It's very small amount stored. So just to function, we need a continuous supply of sugar to work. So if you label sugar with F18 and administer to a patient, if the parts of the brain is not working well, then that shows decreased uptake. That's how FDG PET scan actually works for dementia. And just a historical picture, this was actually obtained by my mentor, David Kuhl, at the University of Pennsylvania, half century ago. And first scan, first human study of FDG and the brain imaging, remarkable advancement. But after almost 50 years later, the image quality of PET scan improved so much. And we used to joke about nuclear medicine is unclear medicine. You've heard that. But now it's a new clear medicine. Just want to let you know. So we should be proud of ourselves. FDG PET, it sometimes is very hard to interpret, so we really focused on statistical mapping technology. This was like 20, 30 years ago. And comparing a normal database, instead of looking at the area of decreased uptake, this statistical mapping is going to highlight area of decreased uptake as a color-coded statistical values. And how this works, like this case, cognitive decline, the clinical question, Alzheimer's disease or not. And if you're really experienced with the FDG scan, maybe you can see some subtle changes, but it's very hard to say this is normal or abnormal. Then we do a statistical mapping. Now you can clearly see precuneus, posterior cingulate, even parietal lobe bilaterally. So your diagnosis changes from don't know to this is definitely Alzheimer's disease, but it's a very mild stage. So this is a value of statistical mapping. Compared to a slice-based interpretation, there is a statistically significant improvement. Both for the beginners and expert can increase diagnostic accuracy. And the purpose of the FDG PET for differential diagnosis, so major 3 common neurodegenerative disorders, Alzheimer's disease, frontotemporal lobar degeneration, and dementia with Lewy bodies. As a nuclear medicine physicians, I think those 3 categories we should be able to differentiate. And then Alzheimer's disease, frontotemporal lobar degeneration, has a lot of atypical or subcategory. And Alex is going to talk about some of those Alzheimer atypical cases later on. Also, I would like to actually emphasize there is a new disease category called limbic-predominant age-related TDP-43 encephalopathy, abbreviated as LATE. And I'm going to actually show some of those cases today. And it's actually very important to remember, I think Alex mentioned the FDG is a non-specific imaging biomarker. But if you think about all of those different types of neurodegenerative diseases, we do not necessarily have definitive biomarkers or imaging biomarker for all of those neurodegeneration. I think amyloid, Alzheimer's disease is certainly, that's the major focus now. But to really make a differential diagnosis, actually FDG PET is actually a very useful tool. It's just not very expensive, widely available. So why we have to make a differential diagnosis? It's therapy. So now anti-amyloid therapy became available, and this is going to be, this works for Alzheimer's disease, but like dementia with Lewy bodies, if you try to treat patients with a neuroleptics, some of those dementia with Lewy bodies, they actually develop adverse reaction to a neuroleptic. So for neurologists and treating providers, they like to know before treating patient, is this really Alzheimer's disease versus dementia with Lewy bodies? So all of those differential diagnoses becomes very important because now therapies are available. And we try to basically triage patient to the right therapy. Since this is a case presentation session, I'll show you some of those images. So this is the first case. 61-year-old man, progressive cognitive decline, FDG. And transaxial scan and statistical map showing area of decreased FDG uptake. If you take a look at the transaxial scan, you see some decreased uptake in the parietal lobe, extending to the posterior part of the temporal lobe. And the subcortical structure is relatively preserved. Occipital lobe is relatively preserved. And there is some structure called precuneus here, and also posterior cingulate. These are actually also decreased on the statistical map, as you can actually see. So this is a typical Alzheimer patient. All right. So Alzheimer's disease, naturally, this has been the focus of investigation for the last many decades, 4 decades. And we also investigated metabolic changes in the Alzheimer's disease. So parietal temporal changes, less frontal changes, unless patient really advanced. And in between is a primary sensory motor cortex, which is relatively preserved even in the late stage of Alzheimer's disease. But we also discovered there is something called posterior cingulate cortex and precuneus is really affected in the very early stage of the disease. And this is better appreciated on the statistical map than the visual transactional map. But you can actually remember this structure when next time you're looking at the FDG scan. Moving on to a frontotemporal lobar degeneration. This is a big category of neurodegeneration affecting frontal lobe and temporal lobe, and said to be the most common early onset. So younger patient comes to the clinic. Still, the Alzheimer's disease is a first concern, but the second, probably common etiology is frontotemporal lobar degeneration. But this is a big heterogeneous category. That's something you can remember. So within the FTLD, there are 3 major subcategories. So behavioral variant of FTD used to be called Pick's disease, or primary progressive aphasia. So aphasia is part of the FTLD, and also atypical FTLD with motor movement disorders such as PSP, CBD, and sometimes MSA is included. And even within this subcategory, there is a subcategory such as primary progressive aphasia has a semantic dementia non-fluent variant of PPA and the logopenic variant of PPA. Amazingly, using FDG and the combination with amyloid, we can sub-categorize some of those neurodegenerative conditions. And this is just a catalog of different subtypes of frontotemporal lobar degeneration, but maybe you can appreciate some difference in the distribution extent of the brain regions affected by frontotemporal lobar degeneration, but also you can appreciate it is highly heterogeneous disease category. So if you're going to see some of those, it's all fit into a frontotemporal lobar degeneration, but exact clinical diagnosis actually varies quite substantially from one category to one other subcategories. All right, so the next case, 70-year-old presented behavioral changes and the FDG PET scan. So transaxial scan and statistical map. So it's a behavioral variant FTD, Pick's disease. If you do autopsy, there is a Pick body in the frontal lobe. So majority of the changes are frontal changes, and the statistical map clearly delineate frontal abnormality with minimal changes in the precuneus posterior cingulate. So this doesn't suggest Alzheimer's disease. And since you're here, I'll give you one interesting findings. FTD, FTLD, you actually pay attention to the caudate nucleus here. It's actually often decreased. And Alzheimer's disease, striatum, including caudate and the putamen, are relatively preserved. But next time you question, is this patient FTLD, not only paying attention to frontal lobe, but it's good to pay attention to a caudate. And if there is a decreased uptake, then frontal circuit is likely affected, more towards FTLD. So that's a small caveat. Just as I said, FTLD is a very heterogeneous category. And another disease which actually falls into a primary progressive aphasia is a semantic dementia. And if you do a statistical map compared to the previous case of typical Pick's disease, this is more like anterior temporal lobe and the less involvement of the lateral frontal cortex, but there is an inferior frontal lobe is involved. So this is a typical semantic dementia. Left side more than the right side, those patients come to the clinic with a language issue, but both sides can be involved. But the big message here is that this case and the previous case, these are all in the big category called frontotemporal lobe degeneration. So it's a very heterogeneous category. And moving on to a dementia with Lewy bodies, so this is a distinct from Alzheimer's disease. Just as I said, clinical diagnosis becomes very important because they may react to neuroleptics adverse reaction. And I'll just show this image, and you see FDG scan and statistical map. And you can respond to this case. But the findings-wise, very similar to Alzheimer's changes, including a posterior precuneus, but also there is a medial occipital lobe. It's a primary visual cortex, which is affected in the dementia with Lewy bodies. And so answer is this, but if you take a look at the transaxial scan, primary visual cortex is a medial aspect of the occipital lobe, which is relatively preserved in the AD, but it's actually decreased in the DLB. There is also another sign called posterior cingulate island sign. Alzheimer's disease, there is a severe reduction in the precuneus and the cingulate. And DLB, quantitatively, it's decreased, but it's relatively preserved compared to the occipital reduction. So it looks like island is preserved, which is called cingulate island sign. So if you see those changes in addition to some Alzheimer's changes, that's a dementia with Lewy bodies. You have to let neurologists know, be careful when putting those patients onto a neuroleptics. And the last category I like to present, but also this is a very important category, is a newly recognized form of dementia. And the limbic-predominant age-related TDP-43 encephalopathy late is one of those conditions. In this case, MRI scans, those people who are familiar with MRI, neocortex is less atrophied, but the medial temporal lobe is severely atrophied. And this is a question for you, FDG, transaxial scan, and the statistical map. What disease is this? Very interesting aspect is the medial temporal lobe and the anterior temporal lobe and the inferior frontal lobe. Those three signs are suggestive of late. And so why this is so important is that age above 80 years old, this has a huge prevalence, and almost public impact is similar to Alzheimer's disease. But more confusing aspect is that, just as Alex indicated, their co-pathology, so two neurodegeneration coexist in the same patient, and the Alzheimer's disease and the late, they can coexist quite significant fraction. So it's not just simply detecting Alzheimer's disease by amyloid is not going to actually get to the final clinical diagnosis. And I'll just show you this one case, 80 years old. There is a generalized atrophy in the neocortex, but also hippocampus is atrophied. This is an amyloid PET. Sylvia is going to talk about amyloid, but this is pretty positive. If you do FDG scan, somewhat inconspicuous, but if you do a statistical map, there is an Alzheimer changes, just consistent with a positive amyloid scan, but also there is a late findings, medial temporal lobe, inferior frontal lobe. So it's very important to kind of recognize co-pathology. We used to work in the nuclear medicine trying to differentiate dichotomous AD versus FTD versus DLB. But now we have to change our interpretation to more what underlying pathology or pathologies best explain scan findings and the patient's symptoms that can benefit from a specific treatment. Thank you so much.
Thank you, Satoshi. Very nice presentation. So we move on to Silvia Morbelli with the talk improving early recognition of AD pathology with amyloid PET.
Yes. Good afternoon, everyone. Let's move to the added value of amyloid PET. And I would like to start with the two very simple images and very few demographic and clinical details about these two patients. These are two patients with amnestic MCI. Both of them are 75 years old. One of them is amyloid negative, the other one is amyloid positive. I just would like to highlight that given the huge body of literature that is now available regarding the clinical use of amyloid PET, just this small information that we have about the patient allows us to define which kind of patients are typically candidate to amyloid PET, the concept of age, to which I will come back in a minute, as well as that while in presence of a negative scan due to the high negative predictive value, the wording is the scan does not support the presence of Alzheimer's disease because there's no Alzheimer's disease without brain amyloidosis. On the other side, despite the revised ATN criteria, despite all the unsolved issue that Alex has discussed with us, if we really want to link the present symptomatology and the presence of brain amyloidosis, we might be more cautious in the wording. So this scan might support the presence of Alzheimer's disease. So I think this is common knowledge for us, but new challenges and new opportunities are coming. So we already know about semi-quantification, but we probably need to know more about some specific way to quantify and harmonize semi-quantification, like the centiloid scale. We need to adjust appropriate use criteria to the evolving clinical scenario. We need to work always on the impact on patients' management. And even a simple question, such as this one, should I repeat the exam over time? As a clear answer from my point of view now in Europe, without disease-modifying drugs, many often the answer is no, because we know that this scan is very highly sensitive. So if you have symptomatology and the scan is negative, there's no reason to repeat a follow-up scan. But you will see in the last part of my presentation that this is one of the questions that might change with the availability of disease-modifying drugs. So this is the future. But I will now make a step back and start by very briefly discussing what we measure with amyloid PET, and then we will discuss the scenario to which we will need to be ready in the next future. So everyone knows that amyloid PET is able to track, all the tracers are able to track amyloid pathology with high specificity. The phase 3 trials were validated against neuropathology. There's no significant binding to the other neuropathological proteins that might be there in patients with older patients with neurodegenerative diseases. Then when we move into amyloid pathology, this specificity somehow stops. We know that these tracers are able to track neuritic plaques, diffuse plaques, and amyloid angiopathy. So while the negative predictive value is extremely high, the positive predictive value, it's a bit different, because we know that patients with amyloid angiopathy has a positive amyloid PET scan. We know that with aging, in general, we will have a higher number of patients with a positive amyloid PET scan, regardless, again, I would say, of the link between present symptomatology and final diagnosis. But still, we know that through amyloid PET, we can differentiate between these two amnestic MCI patients. One of them is negative, so we know that it's very unlikely that in the future, 3-5 years or even more, it will show the clinical evolution to the dementia of Alzheimer's disease. On the other side, it's more likely that the other one will then progress, showing the clinical features of Alzheimer's disease. So let's move to what we need to be ready for. But when we are discussing this topic in Europe, there's a big elephant in the room today with us, is the fact that while we know that disease-modifying drugs are already available in the US and now in other countries, there was a decision last summer by EMA to reject the registration of this drug for a, let's say, a not balance between efficacy and safety, according to the EMA opinion. We are clearly not here to discuss about this decision, but my point here is that from my point of view, this decision is just able to give to us, to European nuclear medicine physicians, more time to be ready to face the challenging and the opportunities that our colleagues in the US and in other countries are already facing. So we have more time to study and we need to be prepared. That's why if we go to the appropriate use criteria that actually are not yet published, but you can read them on the website of the Alzheimer Association, and I'm showing you this table that was obtained by the vote in August 2023. We have some appropriate use criteria that we expected already present in the past. So we know that the value of this tool is more prominent in patients, in younger patients, ideally below the age of 65, but even a little bit older for sure. We know that we have a lot of value in case of inconclusive fluid biomarkers results or when they are not available. We know that amyloid PET can provide information about prognosis, as I showed you before, but I believe that, as Alex mentioned, while today we do not link the degree of amyloid positivity with the further evolution, the new metrics, the centiloids, there are some papers already, might help us to further stratify beyond this distinction between positive and negative. And finally, there are two new indications: eligibility for treatment with an anti-amyloid targeting therapy and to monitor response among patients who have received an amyloid targeting therapy, that I will comment this topic later on. Coming back to Europe, what we do now, but still valid also in other countries. This is the European consensus for the use of biomarkers, in which, as you can see, clinicians in the so-called Alzheimer branch voted to start with CSF biomarkers, maybe fluid biomarkers in the future. We can discuss this, but this is very often, it's a little of variability is present in a different country, but very often this is considered the first biomarker. What happened then? If CSF biomarkers are performed and we obtain A+ and T+ results, so in the suspect of Alzheimer's disease, we have basically the confirmation that we are in front of a patient with Alzheimer's disease, a second biomarker is not needed. Then, if we believe that it's Alzheimer's disease, but the results is A-, then clearly, as Satoshi showed us, FDG-PET is useful because this aspecificity of FDG-PET, the capability to track neurodegeneration regardless of the neuropathological proteins deposition, can guide us through alternative diagnosis. On the other side, in presence of a borderline results, which occurs at least around 20% of cases, even more if speaking about CSF, we add patients that cannot do lumbar puncture, have contraindication, don't want to do the procedure. We will reach around 30% of these patients. Then at that point, if the clinicians want to know about the information about A, as the question is this Alzheimer's disease, then amyloid PET is the answer, because this is the most important information at this point. And I would like to add very quickly that, as we probably all know now, there's a possibility to acquire amyloid PET with the dual point acquisition, in which the early perfusion scan is a surrogate for FDG, because these tracers are all highly lipophilic, and in the first, let's say, 5 minutes, the distribution is similar to brain perfusion, and we know that metabolism and perfusion are coupled. So these are just some examples of a frontal variant of Alzheimer's disease, in which, in any case, the presence of brain amyloidosis is the most important information from my point of view. But as you can see here, this is a patient with progressive non-fluent aphasia, and on the same day, in presence of a negative amyloid PET scan, we can have information about neurodegeneration in the frontolateral and frontoinsular cortex. So this is a case session, so let's move to reading and interpretation. I don't believe I need to go through the visual evaluation of images. I just want to mention, because then we will have information in the cases about visual reading and centiloids and semi-quantification, that at least 2 of these tracers define a positive scan based on the positivity, loss of contrast, high accumulation in the gray matter in just one region, while you will see that the centiloids scale is a composite score. So this might result in some discordant results that we need to be able to deal with now and especially in the next future. We know that these tracers works equally well, although this tab belongs to different patients, but it is in the supplementary material of one of the phase 3 trial. We also know that in multi-center trials, visual reading was quite consistent between central readers and local readers. Very often we can, it's easy, sometimes easier with respect to FDG to report this type of scan, even visually. However, since the beginning, we felt that a dichotomic definition between negative and positive is not enough to capture these complexities. This is a negative result, this is a positive patient, and there are clearly different degrees of positivity. The last one is clearly positive, but in a less severe way, less marked way with respect to the other 2. And I have a question for you, a bit unfair with just one slice, but you have to try. So is this negative, positive, or you are not sure? There are some challenges. Atrophy is one of them. Having a look to the co-registered CT, available MRI that they should bring on the day of PET, we can solve this issue. But still, as you can see, we might, in some regions, have the impression of a falsely negative region due to the idea of a preserved contrast, while it's just atrophy. We are well aware of this problem. So let's move to the quantification landscape. This is a full quantification landscape. You see, this is a slide that I prepared a couple of years ago. Centiloids were mentioned, but very small, below the SUVR family, because they are SUVR derivatives. This matrix is becoming dominant recently, and it's not even a metric, it's a way to harmonize the results of semi-quantification with SUVR with 2 anchor points, 0, young adults in their 20s, and 100, but we can have more, mild to moderate Alzheimer's disease. I will come back to this, but 37 centiloids is the cutoff to enter in one of the trials. The trial that for donanemab that was using also centiloids. What we have learned about centiloids so far, many information. Nuclear medicine is a naturally quantitative discipline. Sometimes when I see too much numbers, I feel a bit afraid, but I see this body of evidence growing in a methodological proper way. We know a lot of things about centiloids. We know that probably the thresholds for positivity might be above 25, but still, we even know that when we look to, you can have a look to the right, it's very summaries in the right side of the slides. when we see them positive is between 21 to 30. We even know that an expert is able to see visual reading positive around 17 sometimes. It's amazing because we don't know so much about other kind of semi-quantitative approaches. There are limitations, but there's really some evidence on this. And these are two negative scans and then a progressive positive scans. And we always had the impression that there's a different degree on positivity. Centiloids are mirroring this impression that we always had. But as you can see, there's a gray zone in the previous slide, and 20 centiloids falls into the gray zone. So sometime we will need to discuss, might want to have further metrics that I will show you, but it's really mirroring what we see. So to comment some cases, I wanted to use cases that are published. So I would like to share with you some cases derived from an ancillary study of the AMYPAD study. I was involved at Central Reader, and these are all challenging cases. So this is not the real world. Luckily, in the real world, many cases are easy. But in this study, cases were included as the local readers were discordant with respect to the centiloids measure with the cutoff of 21, or the confidence of the local reader was low, 3 or below over a 5-point scale. There were 85 scans, and then there were also 15 scans easy to read added. So first question for you. Do you believe that this is a negative, positive, borderline, or you are not sure? This is positive. This is a low-quality image. So for physicists that are here, that I see in the first line, when the quality image is low, visual reading is complex, and sometimes semi-quantification is even more complex. We had the idea of a positive scan, all of us, but with a fair, not so high confidence. Centiloids are 42, so clearly positive, and clearly we increased our confidence. So another example, do you believe it is a negative, positive, borderline, or you are not sure? It is positive. We have a clear impression of loss of contrast, especially in the left hemisphere. It was positive for us, but it's somehow, again, atypical, more occipital, which is not even occipital in the regions for floor beta band, but in any case, and especially in the left side. But there are, and the centiloids was, let's say, negative, 5 centiloids. Why? Due to the volumetric region of interest that centiloids apply, due to the fact that it is a regionalized positivity and centiloids are a positive score. But many software that are now including centiloids, cloud software or others, are also providing other metrics. And in this case, we were also aware of the results of Z-score with the surface projection. And as you can see, there was a confirmation of a positivity in the left hemisphere above 2 standard deviation with respect of a normal subject dataset. So one general comment can be that all the semi-quantitative tools have advantages and limitations, but if we have more than one, very likely they will have different advantages and limitations. And then we were all well convinced. Last case, I think. Do you believe it is amyloid negative, positive, borderline, or you are not sure? This is even less fair because I show you just the sagittal view. You will see this, it's impress the paper on JNM, so you can see then the images. Again, we had the impression of a positive scan with quite low confidence, and centiloids were really in the gray zone, but the Z-score was helping us, because the idea was that posterior cingulate and precuneus were positive, and this was confirmed. So we were then more happy with the result. And what I would like to comment is that we all know that to have Alzheimer's disease, there should be brain amyloidosis there, but it does not mean they should be there with all the metrics. So some, very few patients might have low centiloids value, but they can be positive for visual reading or for other metrics. It will be relevant in the future to discuss this kind of patients. So moving after the results, what happened after the results? We know that amyloid PET can increase diagnostic confidence. Even in a scenario, this is Italy in 2016, without disease-modifying drugs, both in terms of the introduction or discontinuation of this kind of drugs in patients with a negative amyloid PET. This is the IDEAS studies. You might remember that the IDEAS studies was started as a reaction to the fact that amyloid PET was denied the reimbursement in 2013 in the US. The IDEAS study was aiming to demonstrate an impact on the healthcare system in terms of hospitalization and access to the emergency room. They demonstrated with thousands of scans that amyloid PET dramatically affect diagnosis, changes 2/3 of treatment plans, but unfortunately has only a tiny effect on health outcomes, dropping the hospitalization by only 5%. So let's say the primary endpoint was not met. This paper was published in October 2023, just before a further definition of amyloid PET reimbursement in the US, but this time the coverage was granted. Why? Because another history was developing, the history of disease-modifying drugs, especially, I would say at that time, lecanemab. And the reason for which the reimbursement was granted was motivated by the approval of this kind of drugs, since monitoring programs with these drugs may require multiple scans. We are more and more learning how to use amyloid PET also in clinical trials. Initially, it was positive, negative, and as I previously told you, in the donanemab trial, the patient entered based on a clearly positive cutoff of centiloids, 37 centiloids, and also based on tau PET, which will be discussed later on by Alex. This is the results, this is the cutoff to enter, and also these well-evident results in terms of response to treatment is measured based on centiloids again. So there's an evolution of the role of amyloid and tau PET in clinical trials, and while they can measure response to treatment, but the only response to treatment that you want to see is the slowdown of cognitive impairment, the slowdown of the progression of cognitive impairment. There's an important point that is part of the trial. The possibility to think about treatment discontinuation, very interesting for the political stakeholder. There are a lot of information already on this topic, but for the sake of time, we already know that if patients become negative, so the centiloids value goes beyond 25 centiloids, these patients tend to have no significant accumulation after 1 year, because 3 centiloids is just the test-retest variation in terms of, so it's not significant. And similarly, if the centiloids value goes beyond 12, so very close to a young adult value, reaccumulation takes from 2 to 4 years. It's just modeling, but very, very interesting. And the donanemab was also approved for clinical use in the US, and this is a summary of the prescribing information, where you can read that it was clearly reported that you might consider stopping the drugs, the administration, if you obtain a negative amyloid PET. So I believe that this affects a lot our way of working now and in the future years.
Thank you, Silvia, for a beautiful presentation. A lot of information to digest here. So just a little bit also still on the promise of tau PET in that context. We have tau PET imaging tracers available now for quite a while. And there's one of these tracers approved, FDA approved. And now recently, and this is of course good news, also EMA approved. So there will be a tau PET tracer available, commercially available in Europe, hopefully soon. You see the results here on the left side of a healthy control with this uptake without any major cortical retention, and then on the right side in a patient with Alzheimer's disease. Again, also this tracer had to undergo validation versus autopsy data. So what can we do with tau PET imaging? First, with regard to differential diagnosis. And I'm showing you on that slide a lot of images to make the point that, again, the patterns matter, basically. Because tau PET is providing more information than just positive and negative, as compared maybe also to the fluid biomarkers. But it tells us what type of pathology is in the brain and also where it is located and where it is causing damage. And you see this on the left side of the slide. In Alzheimer's disease subtypes, we see typical Alzheimer's disease, a more frontal dominant symptomatic pattern, a posterior cortical atrophy pattern where the patient has no uptake basically frontally, but a lot in the posterior cortex reaching into the visual cortex, and a logopenic variant of progressive aphasia with temporal uptake, strongly unilateral. And you may remember the images that Satoshi Minoshima showed before, these patterns are resembling the patterns of functional deficits in these patients on FDG. So where the tau PET is showing positivity for this kind of pathology, the damage occurs and the FDG PET shows then the neuronal dysfunction, very importantly. And other than in amyloid PET, which has a more globally distributed pathologic pattern and not this regional specificity. So we see where and what type of pathology. Importantly, also now several studies have demonstrated that on the basis of the tau PET pattern, you can also differentiate between amyloid positive and negative subjects, so potentially divide between amyloid and positive and negative subjects, even on that pattern. And on the right lower area of that slide, we can see that next generation tau tracers have been evaluated and are currently also still evaluated with regard to non-Alzheimer's disease tauopathies, such as the 4-repeat tauopathy found in the basal ganglia here in an example of progressive supranuclear palsy. So very importantly, it shows what type of pathology and also where in the brain. Will be difficult to do this with a fluid biomarker for differential diagnosis. Tau PET also has a value for early diagnosis and prediction. And we heard about the amyloid PET already, which can be so early that it is positive in subjects maybe many years before any symptomatic disease onset, which defines a high sensitivity, but at this very moment a low specificity, as we do not know how soon patients will decline unless the quantitative information is also introduced, which may have a value. The tau PET appears later, as we saw on these curves before, so it has an added value in the patients who are already symptomatic, and it works better for prediction from MCI to dementia, which we see on top of the left slide, as compared to MRI and also to amyloid PET, because it is closer to the symptomatic onset. But also it has been demonstrated if we combine the two, so amyloid PET and tau PET, amyloid positive information and tau PET, we can have a high predictive value. And that also is in fact reflected in this new guideline, where it is mentioned that the core 2 biomarker, which tau PET would be here, has a value in early prognosis and prediction. And this is valuable because even in cognitively healthy subjects here, it has been demonstrated if they were amyloid positive and tau PET positive, they would have a conversion rate of about 50% to cognitive impairment within 3 to 5 years. Tau PET also allows staging, as we discussed before. This is the core value, the core 2 value of this tool. We see on the left side different clinical stages with higher disease severity. There's a clear increase of uptake here in the tau PET. We have levels of uptake, as we saw for the centiloid, in amyloid as well, but earlier, as soon as patients are demented or severely cognitively impaired, the level of amyloid in the brain is no longer correlating with the progress of symptomatic onset, because it is more or less a plateau, but still the tau is then correlating. It also reflects the neuropathological stages in the brain, has been demonstrated in trials. Once again, how would you do this with a fluid biomarker? So returning to our question, patient inclusion and therapy monitoring, and I showed this before, and also Sylvia discussed it, that for this trial with donanemab, amyloid PET was used for inclusion, and also tau PET was performed at the beginning for inclusion, but also these tools have been performed subsequently. And I want to comment a little bit on this, on what we can learn here from this. As mentioned, the patients were stratified for tau PET levels in their brain, and with the very low levels they were excluded. With low to intermediate they were included, but also with higher levels of tau. So what has been demonstrated here is that the patients treated by donanemab showed a clearance of their brain with regard to amyloid in the entire population. On the right side of the slide, you can see that 76% reached amyloid negativity basically at 76 weeks of treatment. If we look at the low to medium tau population, these values are even better. So they responded better to the therapy, meaning there's a value in tau PET maybe for including them in earlier stages. And it also has effect on the therapeutic symptomatic response. Again, we see on the left side the entire population, where there has been a 29% slowdown at week 76 as a response to the therapy. But in the low tau population, it has been even 36% slowdown. So potentially it might indicate to move to earlier stages, and only the tau PET can give you that information, because all of them were amyloid positive. What about tau PET changes in follow-up? And this is very interesting, because the idea would, of course, be the amyloid is reduced from the brain and the pathology process is delayed. And that also was in phase 2 for the donanemab substance clearly the case. It was possible here to show that the tau uptake or tau increase in the brain was slower in the treated group as compared to the placebo group. So unfortunately, in the phase 3, this was no longer so clear as we can see here. There was in the entire group no significant effect on tau accumulation over time. However, very interestingly, the subgroup of patients that showed a quick response, a quick amyloid clearance, there's a considerable group of patients with rapid amyloid clearance that were amyloid negative already after 1 year of treatment. They once again showed a decrease in their tau accumulation over time, and also a better clinical response. So interesting value of tau PET for following up therapy response. I just wanted to mention quickly that also tau PET can, of course, be quantified already by now. The visual read depends, as we learned before, on the location of tau pathology, where we should judge, is it positive only in the lateral temporal lobes or also in higher cortical regions for advanced stages. But also there have been semi-quantitative assessment scales introduced, so similar to the centiloid, there's also a centau scale being introduced that may in the future add value, again, not only with regard to location, but also again to quantity of pathology in the brain. All imaging, all information only imaging can provide. So at the end, also a case for you to judge. This is a man aged 72 that recently had difficulties in reading, orientation problems, issues with driving the car and using tools. Neuropsychological tests demonstrated visual impairment, but only relatively minor memory impairment. So we see the FDG PET scan here in that patient, and I'll leave it up to you to judge on where in the brain there are hypometabolic abnormalities here. And this is for the same patient added the tau PET scan. And that's what I mentioned before. It is quite strikingly obvious here that the regions that are tau positive in that case are also the same regions that are affected by neuronal dysfunction. So we would move on now to the question. Does the patient probably have a positive amyloid scan? Does the patient need to see an ophthalmologist? Does the patient probably have an abnormal dopamine transporter status? Does he have an encephalitis, or you're not sure? So please make your selection. And I also show you the amyloid scan here that you can see on the right lower side of that slide. What is really interesting here is to see that the amyloid PET scan is positive throughout the brain. So the patient has amyloid everywhere, but the tau only sits in that regions that are functionally affected. So it is more specific to the region of pathology. So this is a classic case of atypical Alzheimer's disease, in that case here posterior cortical atrophy. An atypical variant. These patients often have visual problems first, and the amyloid PET is, of course, here positive, demonstrating that this is in fact atypical Alzheimer's disease. Tau PET may also provide evidence in the same direction.
I think we are running out of time, so I'm going to just use 1 minute to talk about communication with AD care team. And so caring a dementia patient, it's really a multidisciplinary group of people actually helping a patient from diagnosis to care provider. You can actually take a look. It's a substantial effort to help dementia patient. And imaging communication, of course, nuclear medicine practice, we issue reports. So the report has to be very clear. Sometimes this can be communicated by email or phone call with the providers, but describing key findings, differential diagnosis as we discussed today, and often clinician be helped if we suggest what the next step. Is this test diagnostic? We don't need anything else, or we need to do something, after these exams. If there are multiple biomarkers available, integrating this information into a clinical report can be also very helpful for the providers. But one thing I really like to suggest is that just like tumor board or epilepsy multidisciplinary conference, it's actually very, very useful to have a cognitive disorder case conference. And this case conference can be weekly or monthly, depends on how many volumes of patient you see in the clinic, but including providers, nuclear medicine physicians, neuroradiologists, psychologists, and if needed, pathologists, and the trainees and other things, addressing some of those difficult cases, unusual cases, such as we discussed today, and establishing consensus. So my recommendation from those 3-slide presentation is that recognizing this very diverse group of people helping a dementia patient, but also having a cognitive disorder case conference, if you don't have it, this is going to really actually help your clinical practice and providers. Thank you.
Thank you, Satoshi, for this really important last message for this group, and I fully agree this should be implemented, in particular if it is about new therapies in the future, also to encourage everyone to use imaging for inclusion and therapy monitoring in individual cases. We may start with some questions that have been filed here, and I may want to start with one which is, I think, clinically important, where there has been the question, how could we differentiate dementia with Lewy body disease from posterior cortical atrophy in the brain on the basis of FDG PET? I don't know, maybe Satoshi would like to comment with regard to the FDG PET.
So posterior cortical atrophy and dementia with Lewy bodies, you see decreased uptake in the occipital lobe. But one-to-one correspondence comparisons, the literature is limited, but limited literature does actually suggest dementia with Lewy body has more pronounced metabolic reduction in the medial aspect of the occipital lobe, which is primary visual cortex, as compared to PCA, can be more diffuse, including association visual cortex. And also asymmetry is more common in PCA as compared to dementia with Lewy bodies. And clinically, PCA typically has a longer duration of the disease, eye symptoms, and also younger patient. So combination of those is going to probably guide to the right diagnosis. Amyloid, just as Alex showed, can be positive in both conditions. So amyloid PET scan may not distinguish between those two.
Another one. that is here, should patients have an FDG PET to exclude other neurodegenerative disorders and assess degree of neuronal damage prior to consideration of antibody treatment? And I think all three of us more or less discussed that we would clearly say yes, because the level of pathology of neurodegeneration can be assessed and other forms of neurodegeneration can be captured, and also co-pathologies may be existing. So to assess the formally called N pathology from an imaging person's perspective, I think is an important addition. I don't know, Sylvia, if you want to comment on that.
I agree, and I would like to add that total tau is not a surrogate for FDG, it's more neuronal damage. Maybe FDG is more close to neurofilament, which are, however, not clinical practice, let's say, at least in Italy.
Very good. I'm looking at the watch. I think we are exactly in time. We would thank all the speakers for the really nice presentations and the audience for staying also the entire time.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board of Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/CAF860.